All right, so now we're gonna run through the practical hip exam. And these practical exams are not the most comprehensive thing in the world, but they are gonna cover the vast majority of the pathology you're gonna see in clinic every day to help you feel more confident that you can handle hip pain. So let's get started. All right, and to start this exam, hopefully you watch them walk in the room or walk to the table, but you can actually start this supine. I think this is probably the easiest flow, not necessarily the easiest with every patient. We'll talk about patient population it's not ideal for, but if you have a relatively young person who's able to move well, then supine's a good place to start. First, you'll start with inspection. If you can, try and see the skin around that area. Obviously, keep modesty in mind. This is a very sensitive area. If you need to bring a chaperone in, that's fine. Keep them closed as much as possible, but we need to see the skin to make sure there's nothing going on. From a palpation standpoint, if they do have growing pain, I do want to palpate the ASIS and the AIIS and then also the pubic symphysis. However, if they're having more lateral pain, the biggest bang for your buck is going to be palpation over that greater trochanter. For range of motion, the 3 ranges of motion that I test most frequently are hip flexion, internal rotation, and external rotation. For the hip flexion, that's typically active. I have them bring their knee up as far as possible. Don't have them grab it with their hands, but just actively with their own hips and nothing else to see how far can you flex your hip. And then for internal external rotation, I actually do that passively. So essentially have them relax and I just take them through as far as they can internally and far as they can externally just to see, hey, what's it looking like? And I like comparing one side to the other. Specifically, a lot of times we'll see lacking internal range of motion on one side versus the other. So that can be very helpful. Then with strength, when we're in that supine position, we can also do resisted hip flexion. It can either be done, like I said, with a straight leg or with the knee bent. Then we can real quick test adduction and abduction as well. And neurovascularly, we can check the distal pulses and sensation. And when they're still down supine, then we go into our special test right away, right? We can do that Fadir, so that's flexion, adduction, internal rotation. Then we can go right into Faber. If we want another intra-articular, we can do Stinchfield, which is also hip flexion. And then if we want to, from this position, we can also do our straight leg raise, which is looking for any sort of like sciatic type symptoms or radicular type symptoms. And that essentially covered the vast majority of things we need to do. So you can do a lot of these just all supine, so just one spot. However, we can talk through the seated exam as well. Let's say we have a patient who maybe they're elderly, laying back might be a challenge, or their back hurts, who knows what. We can also do a lot seated. Obviously, from an inspection standpoint, it's gonna be hard to see something when someone's sitting down. So do the best you can, but hopefully watch them walk, at least you can see if they had an antalgic gait or not. From seated palpation, we can definitely do some things. The biggest thing is we can still palpate the greater trochanters, so that's fantastic. We can still do that, and that's honestly our biggest bang for the buck anyways. And from a range of motion perspective, it's kind of hard. You can have them try to bring their knee up into hip flexion. That's a little challenging. You can also kind of passively bring them through internal, external range of motion. From a strength perspective, here we can do actually quite a bit. We can do resisted hip flexion first. So they're seated, bring their knee up one at a time, push down, see how strong their hip flexion is bilaterally. Then we can check abduction with their hands outside of their knees, and then adduction, put their hands between their knees, tell them to squeeze those. And from a special test, it's kind of hard to do like anything like Fadir, but if you wanted to, you could try to actively bring them into maybe some flexion internal range of motion to kind of simulate Fadir, but that is not how the test is done normally. So then ideally, after we've done one of those, probably the supine exam, but if you don't have time for the sitting, that's okay too. Then we're gonna move on to the standing. And the standing, the first thing we're gonna do is the Trendelenburg, right? So we talked about that. Trendelenburg, we're just having our hands on their hips. They're just balancing on one leg for about 30 seconds. We're looking to see, hey, does the pelvis drop? Are they really uncoordinated? Is there not a lot of good balance going on there? Or do they have to constantly catch themselves? Things like that. On top of that, then we can do the single leg squat, which we talked about in the knee video. Essentially, we're gonna have them just, hey, balance on one leg and do a couple mini squats on one side to look at, hey, is the hip dropping? Are they having lots of knee valgus? Does that indicate they might have problems with stability or hip weakness? And on top of that, I want to watch them walk if possible. Hey, do we have an antalgic gait? But really, that's it. It's really not that bad. This will give you a good base for screening out scary intra-articular stuff while looking for the most common things like greater trochanteric pain syndrome, FAI, and OA. This screening does not take very long. It takes maybe a couple minutes max, and it's going to get you the vast majority of things you see every day in clinic and rule out some big, bad, scary stuff. So hopefully that's helpful. All right, so now we're gonna run through the practical hip exam.
This is gonna be our practical hip exam. We're just starting in the supine position because we can technically do everything supine, but in the clinic we can also do some seated stuff as well and standing, but we're gonna start supine. So first things first, inspection. Modesty is important. If we can try to take a look at skin for decency here, we're not going to, but we wanna take a look and see to make sure we're not missing any big rash. Then we do palpation. Think about palpation, working through our ASIS and then our AIIS, and then moving down into the pubic symphysis to see if there's any pain there. But our biggest bang for a buck is gonna be our greater trochanters right there. Seeing if there's any pain with that at all. Okay. Inspection, palpation, range of motion then. Can I have you bring your knee up to your chest for me? Good, now let's do the other side. We're just checking for general range of motion with hip flexion. That's the biggest thing. Good, you can relax. Then I'm gonna take them through internal, external range of motion just to kind of see how we're doing. A lot of times we see loss of internal range of motion with intra-articular pathology. Same thing here, we're just gonna check external and internal. There we go. And then now we do strength. So can I have you bring your knee up to your chest for me? Don't let me pull you down. Good, let's try the other side now. Same thing, don't let me pull you down. Fantastic. And then strength we can do for adduction, have you just squeeze your legs together for me. Good. We can also do bilateral at the same time. Push out here. If we are really concerned about something immediately, we can take them up more here. Say, try to pull your leg in for me. Pull in. Nope. Keep it straight. There we go. Perfect. Good. Sorry, that's bad instructions by me. So do range of motion strength. Then we do on our special test here. And we're going to go onto our fade deer. Really getting that internal rotation and flexion. Good. And a lot of times we'll compare both sides just to see how we're doing and making sure we're having. There we go. And then after that, we'll do the Faber test right here. Drop down the hip. Good. Checking out Faber. Drop the hip. Good. And next I'll go on to Stinchfield. Hold this leg right here for me. Don't let me push you down. Good. Let's try this one. Now bring this up a little bit. Don't let me push you down. Good. And we can relax. Next I'm just going to do straight leg raise. Just bring up like you're checking for any sort of radicular type symptoms. Okay. And then right here's a good spot where we can also do our neurovascular. Look at that lateral femoral cutaneous. And then our different sensations moving down into here, going on to the web space and out to the lateral side. Any problems there at all? Okay. Now we'll move on to some additional seated ones that we can do. All right, so now we're going to move on to the seated part of this. You know, this can be for patients who maybe don't have quite as much mobility or can't get in a supine position. So we can do a lot here. It's not as in depth, but we can still get a good exam. First inspection is going to be challenging, but we want to take a look at underneath the clothing, look at the skin here. For modesty, we're not going to. And then palpation-wise, the biggest bang for buck here is going to be our greater trochanter, checking for that greater trochanteric pain syndrome. And then we do on the range of motion. So can you bring your knee up to your chest here? Good. Let's try the other one, just checking that. Good. And now here, modified, what we can do for internal range of motion, just kind of see how they move. Just generally that can irritate patients who have intra-articular pathologies, checking external and internal. And then strength-wise, I'll have them, can you bring your knee up for me? I'm gonna try to push you down. So bring this knee up, don't let me push down. Good. Check on this side. Good. Next, I have adduction. Can you squeeze my hands here? Good. Now next, can you push out? Fantastic. So we've done that. And obviously here we can't do a lot of special tests. We could do a slump test, but not a lot of whole special tests. If we really worry about intra-articular pathology, sometimes internal range of motion will bring it on, but getting in that supine and doing fade deer is really gonna be our best test. And then now this is our standing portion of the exam. So you can do this in any order if they're standing. A lot of times I'll try to watch them walk in the room if possible to see, but first we'll start with our Trendelenburg. So she's gonna have her hands on her hips and then take one leg off of the ground and just balance. We're just checking that contralateral hip to make sure we don't see a hip drop. And usually this is gonna be like 20, 30 seconds. But for exam purposes here, we'll just speed it up so then you can switch sides for me. Great. And then next we can move on to our single leg squat. So we'll just do one side, for example. You can do the right here and just get in that single leg stance. Yep. And then squat down for me a couple times. Good. And then the last portion is just watching her gait. So she's gonna walk to me. You can stop, perfect, and turn around. Just looking for any sort of hip shift at all or antalgic gait. And that's essentially it. That includes our hip exam, and not too detailed at all, can be done pretty quickly in the clinic.
You just watched a clip from my Master MSK course. If you want to learn more about that, click right here. And if you want more related sports and lifestyle medicine videos, click right here.